Michael Berneris. What immunosuppressive do you use in your patients?
Yes, sorry, I left that part out. So our immune suppressive regimen has been, it was cyclosporin and ATG, but we removed the ATG and now use cyclosporin and MMF. The other regimen that we're quite interested in is sirolimus and tacrolimus, which the Dana-Farber group has shown to be quite tolerable and with good outcome. So.
Thank you, Dr. Berneris, to be here in our country, in our beloved country, Mexico. How do you consider the reduced intensity conditioning for allotransplant in children with acute lymphoblastic leukemia?
Si la doctora está preguntando qué régimen de acondicionamiento está utilizando en leucemia aguda linfoblástica.
No, which is the role of reduced intensity conditioning in acute lymphoblastic leukemia in children, in pediatrics?
So it's a very difficult question to answer. At present, we've published data from the Combined International Bone Marrow Transplant Registry, which have shown very poor outcomes for patients who have had reduced intensity transplant for children. Now, we've also published reduced intensity transplant in adults in a more recent era where the outcomes are actually really quite good. So I think that the question is unknown at this point. With the incorporation of minimal residual disease testing, if you can find patients who are very, very low levels of disease or absent levels of disease prior to transplant, they may be very good candidates for reduced intensity transplant. I mean, after all, the children are the ones that have the most to gain from reduced intensity transplant because they have the longest life to live. So I think that research in this area is really needed, and we just don't know what the answer is at this point.
I am not a transplant person. I am a pediatric oncologist, but I work in a center where we do transplant and we use TBI for conditioning. But I wonder, my question is, which modality of radiation you use for this TMI?
Mm-hmm. So as far as I know, there's only 2 centers in the U.S. Well, there's 2 centers in the U.S. that are currently using TMI. Our center in Minnesota and City of Hope in Duarte, California. And the name of the machine is called tomotherapy, so tomotherapy.com. If you look, you can see it. And it is literally a CT scanner, which then has a radiation head to deliver that radiation to each bone. It's a conformal irradiation, so it's really created for prostate cancer, for lung cancer, for missing esophagus, for missing, critical organs. And we've modified it to deliver radiation to the bones. But I will say that only very few patients have received. So all of the data I showed, none of them had that except for we've only done this in probably about 10 patients so far.
Hi, good evening. Also for Dr. Berneris, please. With this irradiation directed to the bone marrow, some of the complication of irradiations is also the stromal damage. If we increase the radiation dose, if we expect some graft failures because of stromal damage.
Mm-hmm. Sí, le está preguntando, doctor, si quiere hacerlo en español, también le está preguntando usted por el daño estromal que se produce por la irradiación, ¿verdad? Y si esto aumenta el riesgo de falla.
So, I have written about 20 or 30 grants to try and get that work funded. And almost everybody who has reviewed them has raised this point. And it's a real point, and it's a real concern. But the response and the way we eventually got it funded was that we could show that the bone marrow stromal cells, the mesenchymal stem cells, are relatively radio resistant. And the doses that we would irradiate the bone marrow, they're resistant to that. Doesn't mean that we may not get graft failure. I think this concern is the biggest concern of this type of therapy. There's no question about it. So for the most part, we're doing this only in patients who are chemotherapy refractory, people who can't get into remission in any other way. They failed multiple induction attempts.
Dr. Valero asked, which is the best conditioning regimen for adult patients in cord blood transplant? Is okay, doctor? No, you. Yes, we know you treat pediatric patients, but do you advise some conditioning regimen for adult patients?
So overall, what we've, as we talked about on the way over here, what we have tried to do at our center is to really unify the therapy that both children and adults receive whenever possible. And so the vast majority of people who get cord blood transplant at our center are with the conditioning regimen 13.2 gray of radiation, total body radiation. Cytoxan 60 per kilo times 2, and fludarabine 25 per meter squared for 3 days. So that's our myeloablative regimen. Our reduced intensity regimen is 1 dose of total body radiation, 5 days of fludarabine, and 1 dose of Cytoxan.
Okay.
And that seemed to have worked pretty well.
Okay, muy bien. ¿Alguna pregunta más? Doctor Valero, ¿están haciendo ustedes detección de enfermedad mínima residual? ¿Por qué metodología en su hospital?
Sí, en el hospital se hace mediante estudio de FISH y también se hace mediante estudio de RT-PCR. También en forma convencional, cariotipo. Pues bueno, lo recomendable en el monitoreo molecular es mediante estudio de RT-PCR.
¿Están cuidando ustedes que sus pacientes estén, obviamente, con enfermedad mínima residual antes del trasplante para tener mejores resultados?
Así es, lo más adecuado en un paciente con LAL y LAL positivo es llevarlo a una respuesta molecular temprana, una respuesta molecular completa o respuesta molecular mayor, que la mayoría de los pacientes la llegan a obtener, y es aquí donde viene el papel de mantener esta respuesta con los inhibidores de tirosincinasa, a pesar de que los diferentes estudios aún no son concluyentes en cuánto tiempo les vamos a dar. Lo que han recomendado estos estudios es mantenerles 1 año al menos el inhibidor de tirosincinasa, y si la respuesta, la enfermedad mínima residual se mantiene negativa, es suspender. Así también se han hecho estudios de los inhibidores de tirosincinasa en el efecto de enfermedad de injerto contra el huésped, la capacidad que tienen el dasatinib o el imatinib en regular la respuesta de células T, y esto también se ha visto un efecto inhibitorio en la agresividad de la enfermedad de injerto contra el huésped.